can start.
So good afternoon, colleagues, and welcome to our monthly TB Think Tank webinar series. I can't believe this is already our 11th session with you. Today we will be having a discussion. Well, actually, Dr. Dunn, Louisa Dunn, will be presenting on the DRTB mortality file reviews and some of the outcomes and the value of being able to do these audits. And it's an absolute pleasure to welcome you to our webinar series. I'm going to hand over to Nawazi, who's our program coordinator, who is going to introduce our speaker. Over to you, Nawazi.
Thank you, Priya. Louisa Dunn qualified as a medical doctor in the UK in 2007 and has been a member of the Royal College of General Practitioners in the UK since 2015. She started working with TB in South Africa in 2010 and has gained experience in implementing solutions to strengthen TB diagnosis, prevention, and care. She worked as a provincial TB technical lead in KZN on the USAID TB loan program and now works as the clinical manager on the USAID Accelerate 2 program. Louisa's experience also includes clinical research on drug-resistant TB, working on trials evaluating shorter regimens, and novel drugs for drug-resistant TB. Her areas of interest are TB diagnostics, case finding, prevention, and improving quality of care. With that said, I will now hand over to our speaker for the day, Dr. Louisa Dunn.
Thank you, Nawazi. Let me just share my screen. Okay, can you see the presentation? I'll just put it in slideshow.
It's not showing the presentation yet, it's showing the Teams screen. Maybe just check and be sure that it shows the presentation.
Or do you want me to unshare and share again?
Yes, perhaps that might help.
Sorry, everyone. Okay, is that any better?
Yes.
Yes, you can see it.
Perfect. Okay, so good afternoon now, I think it is, everyone, and yeah, thank you for joining us. So today I will be discussing and just covering the drug-resistant TB mortality file reviews that we conducted in KZN. So I think we're all pretty aware, everybody in this forum, that South Africa has a high burden of TB and of HIV co-infection and drug-resistant TB. Although the prevalence of drug resistance has been slowly decreasing in recent years. But KZN was really the centre of a regional epidemic of drug-resistant TB, and that's where we're focusing on today. So the National TB Programme in South Africa, we're fortunate to have leaders that have always prioritised advances in drug-resistant TB treatments. We're also fortunate to have hosted several clinical trials that have really shaped international and national guidelines and policies. So just a quick kind of recap of where we are and where we came from. Sort of pre-2015, it was all the 2-year-long regimen with a really high pill burden and 6 months of injections as well, and all the associated adverse effects of that. And then we moved to the shorter regimens. So from 2017, we had the first shorter 9-month regimen, still with the injectable. And this was followed in 2018 with the first all-oral MDR regimen with bedaquiline as well. And then in 2019, that was our most recent 9-month regimen. So that was all oral again, with the addition of bedaquiline and linezolid and the removal of ethionyamide from the routine short regimen. And then most recently and most excitingly, since September 2023, we've had the rollout of BPAL-L. And alongside those regimen changes, we've had clinical access programs really increasing access to the population of novel drugs as quickly as possible. So we had the bedaquiline clinical access, delamide clinical access, which is ongoing, and then most recently the BPAL clinical access program. So if we look at the mortality or the treatment outcomes in line with the changes in treatment regimens that have been available, we can see that treatment success rates have improved with the introduction of shorter regimens and with newer and more effective drugs. But unfortunately, high mortality rates have continued to be observed in drug-resistant TB. So with that in mind, we were working on the USAID sponsored TB LOM program in KZN, and we were supporting 4 districts within the province. So we looked at GRTB mortality in those areas, and as you can see, it is much higher, or was much higher than we would have wanted to see. So in 2020, combining the regimens, we had mortality rates of 27%, 23%, 29% and 14% in the district. So we set out to do some in-depth kind of assessments and mortality file reviews to really kind of dig a bit deeper into what was really driving these high mortality rates, given that, we really feel like we've got good regimens and good drugs and things that we're using. So we had several objectives. The first was that we really wanted to determine, like, what are the risk factors and the characteristics of the people who are dying while they're taking drug-resistant TB treatment. And the idea of that was to really try and enable that we can identify high-risk patients at baseline and target interventions towards those risk factors. Secondly, we wanted to look into the treatment journey. So what's happening to people while they're on DRTB treatment before they die. Thirdly, we wanted to conduct a clinical audit to look at the quality of care being received. And for that, we used the what was the current South Africa guideline on management of rifampicin-resistant TB from 2019, and we used that as our standard. And then we wanted to conduct a mortality review and just have a look at, like, what do we think are contributing factors? What is the cause of death? Where are people dying? To just find out a bit more information around that. And then finally, be able to use all this information to be able to make recommendations on targeting interventions. So in order to do that, we carried out retrospective mortality file reviews. The population we looked at was people who died while they were taking drug-resistant TB treatment in 4 districts in KwaZulu-Natal. We conducted 2 sort of rounds of this. The first was a cohort from 2020. So these were people who initiated treatment between January and June 2020, and we were able to look at 30 files from that cohort. The second cohort of people we looked at were people who initiated treatment between April 2021 and March 2022. So in order to conduct a sort of a standardized file review, we developed a DRTB mortality audit tool to enable us to do that. And that had several sections. So the first was looking at the individual demographics and characteristics and risk factors. The second was looking at the history around their TB and their TB diagnosis. The third was their HIV history. Then the treatment journey, including regimen choice, response to treatment and adverse events. Then came the clinical audit, and then finally the mortality assessment section. We conducted descriptive statistics on our findings. As I mentioned, part of the treatment journey was looking at adverse events. So in order to try and standardise, how this was conducted, we looked at all aspects of the clinical file. So we looked at the TB clinical stationery, so the tables where AEs are captured in the TB clinical stationery. But we also looked at the progress notes written by the doctors and clinicians, the nursing notes, laboratory results and ECGs as well. And we used a standardised grading scale for drug-resistant TB adverse events, so that the file reviewers were able to standardise like how they're grading the severity of SAEs or AEs that they are encountering in the files. So a severe adverse event was something we classified as a grade 3 or higher, or any adverse event that was severe enough for the clinicians to either temporarily or permanently suspend a drug, and anything that met the serious adverse event criteria. So on the right, there's just an example of some of the more common SAEs from the grading scale and what would have been a grade 3 or sort of severe adverse event. So it would be things like a prolonged QTCF over 500, a hepatitis with an ALT over 200, or myelosuppression with an HB that dropped below 8 or platelets below 50. So that's just to give a short idea of that. So in terms of the process and how we conducted this, so we would start by identifying a team. We did want each team that was reviewing a file to be led by a clinician who was experienced in treating, well, trained and experienced in treating drug-resistant TB. And other people that were invited to participate were TB coordinators, facility management, the TB focal team, and any allied health professionals that had an interest. And we conducted these reviews once every quarter. And the cohort we chose would be the cohort with the most recent DRTB outcomes available. So usually about one, we'd be doing a mortality review about 12 months afterwards. So in terms of the files, we would obviously, in collaboration with the facility, pre-pool the files based on EDR web data of who had died outcomes. And we would request to have the outpatient, the inpatient nursing records and prescriptions available to review. The file reviews were conducted with the standardised DRTB mortality tool, with each review led by an experienced clinician. We captured, we had paper forms, but also had the ability to capture electronically as well. So after conducting mortality audits, the protocol was to conduct feedback meetings with the medical management, the TB team, TB coordinators, and sort of interested parties available. And at that point, to go over the results, the summary findings for that facility. And we also always made a point to present the patient summaries of each individual who had had their file assessed, because it really kind of brings to life, you know, the patient story and the patient journey of the people who we had reviewed. And then finally was agreeing an action plan and, you know, an improvement plan and responsible people and timelines for action at the end of that process. So looking at the mortality tool, there was a development process that started off with the NDOH clinical audit tool, and that was expanded to include some other sections, as I covered earlier, in terms of the different areas we wanted to look at. And that was put onto a paper Word document, and we also, as a program on TB Law, used REDCap. And then subsequently developed an Excel-based tool so that we could support institutionalization of the process. So here is just a snapshot of the Word document. As you can see, it's pretty straightforward, simple questions with sort of tick box answers. And then when this was put into the Excel document, this started off with just a front tab with instructions and sort of the demographics of the facility and the audit date and time and the cohort. And then there was a separate tab for each section. So the demographics of each individual whose file was being reviewed could be captured on one tab, and that would pull through to all the subsequent tabs. And then the checkbox sort of answers from the Word tool were just put into drop downs with availability for free text comments as well. And then on the Excel tool, to just really facilitate the kind of the summary and of findings and analysis at a facility level, we had a dashboard table as well to just allow that kind of immediate sort of results under each section, so that facilities could easily see their findings. And then finally, an assessment and recommendations tab where we could document best practices and document an improvement plan that was specific to that facility. So looking at our results, as I said, we did two kind of cohorts. So the first cohort was conducted looking at people who started treatment between January 2020 and June 2020. And we were able to review 30 records from that cohort. Then the following year, we looked at a second cohort. So that was people that initiated treatment between April 2021 and March 2022. And in that cohort, we were able to look at 58 files. As yet, we haven't put together a sort of a pooled analysis of all 88 files. So what I will present today is the initial findings from the 30 files, but I will at the end actually just do a comparison, just showing what some of the similarities and key differences were between those two cohorts. So just to recap, all of the people that we reviewed during that period were on the 2019 guidelines. So they were receiving either the short 9-month regimen with 2 months of linezolid and 4 months of high-dose isoniazid in the intensive phase, followed by completion of 6 months of bedaquiline, and then a full 5 months continuation phase of levoclavazamine, pyrazinamide, and ethambutol. Those that were on the long regimen would have received one of the 4 long regimens within the guideline, with the core drugs of bedaquiline, linezolid, levofloxacin, clofazimine, and taurursodiol. So if we start off by just looking at the demographics, we found a very even split between gender, so it's 50% male, 50% female. When we looked at the age, we found that the median age was 40 years, sort of overall. But we noted a fairly big difference between the median age in those who are HIV positive and those who are HIV negative. So as you can see, those that were HIV negative had a much higher median age of 78 years compared to 38 years for HIV positive, although that wasn't statistically significant on this 30-file cohort. But what you can see from the graph here is that most of this cohort were of a younger age, with 43% being 36 to 55, so in that real sort of working and employed age group. So looking at risk factors, there were some flags that came through quite strongly, the first of which being HIV co-infection. So of the first 30 files that we reviewed from 2020, 27 were HIV positive, so that was a 90% HIV co-infection rate. We also noted high rates of unemployment at 57%, 50% had had a previous episode of TB, and 40%, so 12 out of the 30, were noted to be malnourished as well. So looking a bit more into some baseline characteristics, as we said, malnutrition was something that came out through quite strongly. And if we break that down into weight bands, we can see that a lot of people were underweight. The median weight for the whole cohort was 49 kg, and over a third of people, 36%, weighed less than 46 kg. Other things we picked up from the sort of the baseline characteristics were that 45% of people had some kind of baseline abnormal vital sign. Usually that was an abnormal heart rate. So the mean heart rate at baseline was 126, with a range of 107 to 153. We also noted a lot of people had a baseline hemoglobin that was lower, baseline anemia, with 57% having an HB below 10 at treatment start, which is in keeping with, they were all diagnosed with TB, high rates of HIV co-infection, and high rates of malnutrition as well. So when we looked at sort of timelines, we've looked first at diagnosis to treatment start and found a median time of 5.5 days, so just slightly over the sort of target 5 days to treatment start. And we break that down to look at different groups, so gender, HIV positivity, employment, and malnutrition, to see if there was any difference between time to treatment start, and we didn't find any significant difference between those groups. We then looked at time from treatment start to death, and we found that the median time was 58 days from starting treatment until the time of death. And again, we looked at different groups to see if there was much difference between them. And we didn't find any statistically significant difference between the groups, but we did note that the HIV negative cohort seemed to die earlier than the HIV positive. So their median time to death was 27 days compared to 65 for the HIV positive people. So looking at TB history, as I said, 50% had a previous episode of TB. And 13%, so 4 out of the 30, had had 2 previous episodes of TB. And we looked at the outcomes of previous episodes as well. So of those 15 that had a previous episode of TB, 9 out of the 15, so 60%, had a previous successful treatment outcome, but 6 out of the 15, so 40%, had a previous loss to follow-up outcome. We also looked at the type of TB, so the TB site, and found that most people have pulmonary TB, but there were 5 out of the 30, so 17%, that had extrapulmonary TB. Most people were diagnosed with gene expert. Excuse me. And when we looked at regimen type, we found that about 2/3 were on the short regimen compared to just under 1/3 on the long regimen. So when we looked at the HIV history, as I said, we found a high rate of HIV positivity, so 27 out of the 30, so 90% were HIV positive. But we delved a little bit deeper into that HIV history and found that of those 27, 25 already knew their HIV status. So it wasn't a new diagnosis of HIV. So these people had obviously had some kind of engagement with healthcare services prior to the current diagnosis. And then we saw quite a big drop off to those who were actually on ART. So only 70% were actually on ART at the time of diagnosis. And then finally, a bigger drop-off when it came to viral load suppression. So we found only 22% of the 27 HIV positive were actually virally suppressed at the time of their diagnosis. So kind of in keeping with that, when we looked at the CD4 counts, we found very low CD4 counts. So 81% of the CD4 counts were under 200. Most of those were under 100, and actually 37% had a CD4 count that was very low, under 50. So moving on to some of the treatment journey findings, we looked at severe adverse events that were experienced by people during treatment at some point before their death. And we found that 23 out of the 30, so 77%, had had a severe adverse event during the course of their treatment. And the top severe adverse events that we identified were myelosuppression, which affected 40%, nausea and vomiting, which affected 20%, and hepatitis, which affected 10%. We did identify in total 28 SAEs because there were some that experienced more than one SAE. And the FAR reviewers noted there was poor recording and reporting of severe adverse events in the correct sort of place in the clinical stationery, and they identified that there were gaps in the recognition and management of adverse events. So just looking a little bit deeper, we had sort of obviously high rates of myelosuppression, and we know from the risk factors that we've covered already that there were sort of high rates of baseline anemias. So we broke that down into ranges, and as you can see that 59% actually had a hemoglobin that was under 10, so 17 out of the 30, and in fact 23% had a hemoglobin under 8 at the time of treatment start. And when we looked at those files, we found that there were 2 people that were started on DRTB treatment with the HB below 8. And when we looked at the clinical audit, of the 12 people who'd had myelosuppression, the linezolid was sort of suspended at that point in 58%, so 7 out of the 12 incidents of myelosuppression. So moving on to the clinical audits, this was based on it was included all of the questions from the National Clinical Audit Tool. And we added a few more in as well, just to expand on some of the areas we were interested in. And it was broken down into sections, looking first at the baseline assessment. And the score here was good. It was 85% overall. And the main thing, this was generally done very well. And the main thing pulling that score down a bit was visual acuity testing at baseline. Then again, the next section was treatment initiation. And again, good score was 80%. Most things, again, were done very well in this section, but we found some things that flagged up were people not being put on the appropriate regimen according to the current guidelines. So that might be things like people having both INH mutations but staying on the short course regimen, or people with a history of previous exposure, sort of prolonged previous exposure to second-line drugs, being on the short regimen. But the main thing that we found in this section was actually people being placed and prescribed on inappropriate doses. So people that were put on doses that were outside of the dose per weight ranges that were supplied in the guidelines. So sometimes that was sort of underdosing a bit, but more often people above the upper limits of the dose per weight ranges. Then on the monitoring and management of treatment, the score here overall was 59%. And it's worth noting again that most indicators were over 90%. So most things in this section were done very well, but there were some things that were consistently low across the districts and different facilities that seemed to be the key issues in this area. The first was the second line LPA results being reviewed and documented. The second was the follow-up visual acuity testing for people who remained on linezolid. Then there was the linezolid being withheld once the HB had dropped below 8 was 58%. And we also found very low rates of cotrimoxazole prescription for people with HIV co-infection. This is particularly important here because we've seen that this was a group of people that had very advanced HIV disease with low CD4 counts. And then the final part was the mortality assessment. And here we found that most people died in hospital. So most people were inpatients at the time that they died, with 23 out of the 30 being inpatients, so 77%. But there were still those that had died as outpatients, where we know much less about the circumstances surrounding their deaths. When it came to identifying a direct cause of death, the reviewers identified a direct cause in 41% of the files, so 12 out of the 30, which is quite low because I think sometimes the notes are a bit scanty and it's a bit difficult to really confidently say like this is what happened. And certainly those that died outside of hospital, we weren't able to establish what happened. But we also looked, so out of those that we did have a direct cause of death for, so 13%, it was felt to be TB. But we did also look at contributing causes of death. And when we think back of the findings of the HIV co-infection, SAEs, the risk factors that we found, most people had a host of kind of things that really contributed to their cause of death. And that was things like the HIV, TB, various comorbidities and SAEs, as we see listed here. So what we've presented so far is looking at those that were in that 2020 cohort, those first 30 files. But I just wanted to share like a bit of a comparison between the 2020 files we looked at and the 58 files we looked at from 2021 to 2022. So if we start off with gender, again, we found not quite an exact even split, but a fairly even split between males and females. When it came to median age, it was 40 years exactly in both cohorts, and we saw that similar picture of it being a much lower median age in those who are HIV positive compared to those who are HIV negative. So with our HIV negative cohort, it's really those in the elderly age groups that we need to be worrying about. For risk factors, it was very similar in terms of the things that were flagging up. There was HIV co-infection, malnutrition, history of TB, unemployment, baseline anemias, and old age. Then looking at TB history, we found 50% had a previous history of TB in the first cohort from 2020, and this had dropped a bit to 36% in the second cohort. But otherwise, very similar TB history. So pulmonary TB was 83% in the first cohort and 84% in the follow-up cohort. And again, 2/3 were on the short regimen and 1/3 on the long regimen. So a lot of similarities in that section between the two cohorts. Then looking at baseline characteristics, again with that, a lot of the baseline anemias, we found 57% with an HB below 10 in the 2020 cohort and 60% had the same below 10 in the 2021 to 2022 cohort. One difference we did see was a difference in the baseline median weight. So if you remember from the 2020 cohort, we saw lots of low weights with a median of 49, whereas in the follow-up cohort, the median weight was 58, so a much healthier baseline weight. And we also tended to find the heart rates were slightly lower. So the mean heart rate in the first cohort was 128 compared to 105 in the follow-up cohort. And then finally, when we looked at the baseline chest X-ray results, we categorized that as either being normal, consistent with TB, and then consistent with TB extensive disease, and other findings. So we found that for baseline chest x-rays, 32% had extensive TB disease in the 2020 cohort, compared to 24% in the follow-up cohort. When we looked at HIV history, we also found a lot of similarities, but one main difference. So we had 90% were HIV positive in the 2020 cohort, but when we went back and did the 2021 to 2022, we found that that was actually 76%, which is much closer to what we observe in KZN for HIV co-infection in drug-resistant TB, which is usually just over 70%, about 72% is usually where it sits. But what was similar was, again, the high rates of people that already knew their HIV diagnosis prior to engaging in care for their drug-resistant TB diagnosis, and then a significant drop-off for the numbers that were on ART and the numbers that were virally suppressed. Again, low CD4 counts in both groups, not quite as low in the follow-up cohort, with 102 as the median CD4 count compared to 64 from 2020. Then again, when we looked at adverse events, we still found very high rates of severe adverse events in 2021 to 2022, but it had dropped. So we had 77% had experienced an SAE in the 2020 cohort, and that had dropped to 60% when we followed up. What was consistent was the top SAEs experience was still myelosuppression, severe nausea and vomiting, and hepatitis. Then when we looked at the mortality section, we found slightly more direct cause of death attributed to TB, so 21% from the follow-up cohort. But we found more people dying as outpatients with less kind of known about the direct circumstances of their death. So 31% died as outpatients in the follow-up. We added some questions to this section after doing the 2020 cohort, so we had a little bit more information than we had, and we found that of those who had died, there was only in over a third, so in 36%, there was no documentation of any kind of recognition of any clinical deterioration by the treating clinicians. And I think with the benefit of hindsight, when you're looking at a file kind of critically and you know that the patient did die, we were able to kind of pick up things that maybe could have been picked up on before those patients went home or before the time of death, and kind of picked up and acted on a little bit sooner. The reviewers did find along that vein that there were missed opportunities in the management of adverse drug reactions in 41% of the patient files. And we found that in a third, adverse events were felt to be a contributing cause of death. And then finally, we found that when we looked at was the regimen changed, so were any drugs stopped or started or paused, or any regimen changes during treatment, and we found only 10% of the files had any regimen changes during treatment, which is significant when we look at the number of people that have had severe adverse events was 60% in that cohort, and only 10% had changes to their drugs or treatments. So just to summarise some of the key findings that we have a roughly even split between gender. The median age in both groups was 40 years, but with higher age in HIV negative population. We had consistent risk factors of HIV co-infection, unemployment, previous TB, baseline anemia, malnutrition, old age and other comorbidity. We found high rates of TB-HIV co-infection in both groups, but high rates of known HIV infection showing pre-existing engagement in care, and low rates of viral suppression showing challenges with engagement in care, and advanced immunological suppression in both groups. We found high rates of severe adverse events, although this had dropped from 77% in 2020 to 60% in 2021 and 2022. We had consistent sort of most frequent SAEs of myelosuppression, severe nausea and vomiting, and hepatitis. And that was accompanied by low rates of changes to treatment regimens. And there were identified missed opportunities in management of SAEs, and they were identified as contributing causes of death. Looking at the key findings from the clinical audit, a lot of the reviewers noted that the patient notes were inadequate in terms of usually the clinician notes and the progress notes, and that there was poor recording and grading of SAEs. Particularly also there was poor documentation of second-line resistance patterns, and we did find facilities with quite a lot of missing files as well. In terms of the clinical management, the main findings were drug dosing outside of specified dose and weight ranges, low prescription rates of cotrimoxazole for HIV co-infected patients, and there were gaps in some of the patient monitoring with laboratory testing, ECGs and visual acuity testing, and there were gaps in recognition and management of SAEs. So the summary findings from our mortality assessment was that most people are dying as inpatients in hospitals, but there's a significant portion actually are dying as outpatients without us recognising any kind of problems or deterioration before they go home. And there was high rates where the cause of death wasn't completely clear from the notes. And so there wasn't as many deaths attributed just directly to TB as we had possibly imagined. So following carrying out all of these file reviews, we did want to have a response to it with Department of Health and particularly our provincial colleagues. So we did share a mortality review report with them and collaborated with them to hold a DRTB mortality roundtable in April of last year, where all of the districts were invited to attend. We did develop a comprehensive action plan for implementation, and that has been shared. And then the provincial Department of Health held a drug resistant TB mortality workshop that they piloted in Etaquini, which we supported with, and was very successful. And then following that, there was DRTB training conducted in June of last year, really implementing a very practical kind of case-based model of training, which again was well received. And we have developed an HIV/TB integrated, very case-based practical training package, and that's been developed based on these specific mortality findings. And then finally, sharing of tools to support institutionalization of conducting these in-depth file reviews for people who have died. So the mortality action plan that we have so far is broken down into sort of different sections. So looking at, for instance, HIV-related factors, TB-related factors, comorbidity-related factors, data factors, pharmacovigilance, and there's a very strong emphasis on how. So rather than saying like we need to do something, there's a lot of detail on the how we are going to achieve that thing. And also a lot of emphasis on horizontal communication, because there's a lot of sort of steps in what we found that really, if everybody's talking to each other and supporting each other across all cadres and all healthcare workers who are working with a patient, and there's no kind of hierarchy in who can say what or raise a concern or flag something for a patient, we really feel that would be supportive of reducing mortality. We also shared some associated tools, so a vulnerability assessment that can be conducted at baseline at treatment start, a clinical file quality assurance check to make sure everything is complete before a file or patient leaves an outpatient, equipment checklists, activity checklists for people managing a DRTB clinic, and then job aids like the SAE list, the AE grading scale, and drug dosing table and monitoring table from the guidelines. And then we really were trying to work towards institutionalizing the mortality audits, as we said, with the Excel DRTB tool. And this is just an example here of working really with the team, and this was Amajuba district, really setting up teams to conduct file reviews within the facility, training on completing the process, facilitating discussions around the findings and the gaps. And just finally, just a note that it's maybe a little bit less doom and gloom, because mortality presentations can be a little bit gloomy. Just some of the progress that has been made in KZN. So in these districts, I haven't put together for the whole province, but this was looking at these districts and these specific cohorts that we were reviewing. So quarter 1 to 2, 2020, and then quarter 2, to quarter 2021 to quarter 1 2022, we can see that there has been gains made in mortality rates. So when we look at the short regimen, mortality rates have dropped from 25% down to 9%, and the long regimen 18% down to 14%. So overall, we've had a drop from 23 to 11% in mortality rates between those two cohorts. And then finally, we can't really not mention COVID because it was obviously all happening around the same period of time. So when we look at the first cohort, the first one, half of it was actually before the first lockdown, so presumably sort of unaffected by COVID. But the second part of that 2020 cohort, was after the first lockdown, but it was before the first wave of COVID. Then in the 2021 to 2022 cohort, that started just at the end of wave 2 of COVID and included waves 3 and waves 4 of COVID experienced in KZN. So finally, in conclusion, we see that shortened DRTB regimens and the introduction of new and more effective drugs has led to improvements in success rates in KZN, but mortality rates have remained high. We feel that these findings from the mortality reviews can be used to target interventions into action plans. With the identification of consistent risk factors supports, the identification of high-risk people right at the start of their treatment, so that we can put in place enhanced case management and full MDT involvement throughout their care. The high rates of HIV co-infection and unsuppressed viral loads was a consistent finding, and that really supports the need to target interventions towards TB-HIV integration, and particularly focusing not just on what happens once they have drug-resistant TB, but includes early TB diagnosis in people living with HIV and retention in care and viral load suppression for people living with HIV, and then obviously integrated care once people are diagnosed with TB. Then the findings we had related to SAEs and the consistent gaps in clinical audits, really with a safe programmatic rollout of the shortened regimens, it needs to just pay attention to not just capacity strengthening at the start of rollout, but ongoing support and ongoing mentorship for decentralised facilities, intensive active drug safety monitoring, and then finally the institutionalisation of clinical and mortality audits and file reviews. So I'd just like to finish with acknowledging USAID, who are the sponsors of the TB Long programme, and the USAID Think TB Long team, who obviously supported and implemented a lot of these file reviews, the Department of Health, who we couldn't have done this without, and who collaborated with us at every level from provincial to district and facility level, and who have gone on to do extensive work around mortality for TB within the province themselves. And then finally to the TB think tank for the invitation and the opportunity to share our findings.
Thank you so much, Dr. Louisa Dunn, for your time, and thanks for that really, really, really relevant presentation. So I'll now head over to our questions for today's session. People in attendance, please don't forget to just add your questions or comments you may have under the Q&A tab. So our first question we have is, what are the measures and thresholds that could define patients with clinical deterioration? What happens once it is identified?
Yeah, so in terms of measures of clinical deterioration, I mean, it's quite broad, really. So some of it might be actual kind of parameters that were within, sort of objective parameters, those things like vital signs that were abnormal, deteriorating laboratory signs, sputum results that are not, converting, that kind of thing. But also what's kind of reported by the patient as well. So things like what's documented in terms of their side effects and severity of symptoms, whether symptoms are resolving, ongoing weight loss, are other things that can also just help you to pick up that this person is not not doing well. And that was something we came across quite a lot, actually was weight. So sort of sudden, quite rapid drops in weight prior to a deterioration and a death. So looking at really quite holistically at the whole kind of picture of a patient, from objective measures to what they're reporting as well, can all be used to kind of assess whether there's a deterioration.
Thank you for that. Our next question asks, as the new guidelines from September 2023 recommend follow-up assessments, would you adjust your auditing or monitoring tools to extend to post-treatment?
So for our purposes, all of the people died, so there wasn't really like there's no sort of post-treatment follow-up. But certainly for clinical audit purposes, where we're looking at people who have all different outcomes, then yeah, I do think it's important to look at the post-treatment follow-up. There's a significant burden of sort of morbidity associated with previous history of TB and ongoing symptoms. So yes, I certainly would include that in a clinical audit tool, but I think for the mortality audit purposes, there's not really much follow-up we can do after their treatment outcome.
Thank you. We'll just be waiting for a few more questions to come through in the meantime. So this, okay, 2 seconds. So I have a question here asking, do you have any idea of the proportion of patients in both cohorts who were lost to follow-up and then arrived in hospital when they were very ill?
So in terms of those who were lost to follow-up, do you mean from a previous episode of TB? I think we were sitting, I'm going to struggle to pull it off the top of my head. It's on the slides, how many had a previous lost to follow-up outcome, and I think it was around about 16%, but don't quote me, it's on the slides. So we do know how many were lost to follow-up. In terms of those who were very sick on arrival, certainly in the follow-up for the 2021 to 2022, we did include actually like the baseline functional status, because we can look at heart rates and chest x-rays and things, but often, you can have somebody walking around with a horrible looking chest x-ray that just doesn't look that bad, in real life, and you can have someone with not even that much on their chest x-ray who's really, really at an advanced stage of their illness. So we added in the baseline functional status at treatment diagnosis. So we put in that whether people were, independently walking and self-sufficient for their ADLs, down to, needing aid for walking, wheelchair and dependent for all needs. So we did add that to the second cohort, we do have a bit more information on that second cohort, but as I said, we haven't kind of finished pooling and analysing all of that yet. I can actually just give you an idea. I'll come back to you in a few moments after, and I will be able to give you a percentage for that just now.
Okay, we'll do that. Our other question states, the improvement in the mortality rate is very encouraging. Can you identify what were the main measures that were put in place that you think helped to curtail the deaths?
I mean, it's very difficult to say, which specific thing, had any specific cause in terms of improving mortality rates, because it's a package of kind of interventions really. I think probably one of the most important things to do is just get started. I think when you start to look more closely, just by kind of just as a consequence of looking closely, I think it does change people's attitude and people's sort of what they're kind of doing in the current time. I think a lot of it boils down to we did a lot of work around adverse events recognition, management and documentation. So that's possibly something that has been effective. We also did a lot around sort of identifying people who were high risk at the start, and just that awareness that actually this person is at high risk of dying. These are the people we really need to kind of be watching and intensifying treatment.
Thanks, Louisa. Do you perhaps have the proportions now on hand, or should I go to the next question?
Hold on.
Or if need be, we can respond to that individual via email.
Yeah, I'll get it. I'm just trying to pull up our reports. Hold on. Okay, yeah, so baseline functional status in the 2021 to 2022, we found that 47%, so just under half, were just independently mobile. But that means that over half were needing some kind of assistance. So 7% were mobile with a walking aid or with some kind of assistance. 22% were in a wheelchair, so not able to stand and mobilize. And 14% were dependent for all of their needs, including self-care. So that was the breakdown we got, and that was out of the 58 files that we did 2021 to 2022.
Thank you. And we have here, it's a statement, and yeah. It says, much has been made of decentralized care, but many of the patients presented needed intensive support from a multidisciplinary team, such as nutritional support and active management of side effects are critical, but unclear to what extent these were available in the decentralized care settings.
Yeah, and as you say, there's a big difference between different decentralized sites and what's available. A lot of decentralized sites are hospitals, so do actually have significant access to services and to allied health professionals. But even one of the things we've included in the action plan is that actually, if you have people coming into care and they have comorbidities, all of those people, if those comorbidities are not optimized, we should be discussing them. So even if we don't have on hand a physician that we can refer to directly within our facility, a discussion needs to take place on how we're going to optimize that. In terms of the malnutrition, yes, it's a really difficult one to tackle. Our feeling was that this is just further support that those who are malnourished, so those with a BMI below 18.5, should be admitted at the start of treatment, which should give them better access to nutritional support to kind of get them over that hurdle before they become outpatients. But yes, it's a good comment. There is not even distribution of resources across facilities, districts, provinces as well.
Okay, thank you. So keeping in mind that this is a clinical audit, are you able to comment on the care? Are you able to comment on the role of psychosocial and economic support interventions in improving mortality for these cohorts?
I probably can't comment. We didn't sort of collect information on that, but what we do see is that there's high rates of unemployment, high rates of malnutrition. So in the same way that we know TB is a disease of poverty, and I think death from TB is also a symptom of poverty. So yes, there's definitely gains to be made in addressing the psychosocial and economic factors that we identified.
Thank you, Louisa. Next one. It seems there's an increase in proportion with advanced HIV disease in the 2021 to 2022 cohort. It also seems some of these had previously engaged in care. Do you have a sense of reasons for disengagement in the care?
No, unfortunately, we don't know why there was disengagement, but that was a very consistent finding across all sort of 88 file reviews that we did, was that the high rates of HIV co-infection was accompanied by previous knowledge of the diagnosis. So we know that people have access to care, and we know that they're then having very low rates of viral load suppression. So I think it's difficult to kind of comment on that because we don't have like the clinic records and their previous HIV records to review from their local treating clinic. But I think what that does do is show that we need to start looking at at facility level with our colleagues that are working with HIV and looking at those people that we're struggling to retain in care, and similarly doing like a deep dive into like who are these people, what are their risk factors, what are their reasons for not having suppressed viral loads, to sort of further target that.
Thank you. We have a question that asks, did your team find deaths attributable to COVID-19, especially the fact that the cohort reviewed was around the COVID peaks?
Yeah. So the 2020 cohort was before any COVID waves. Well, first of all, I should say we didn't identify any files out of the 88 where there was like a confirmed COVID infection. And this was at the time where we were doing, well, I think most facilities were having a baseline COVID test at the time that people came to them. So we didn't identify any files that had a positive COVID test. The second thing is the 2020 cohort was, the first half of that was before we had any COVID cases in South Africa. The second cohort was before the first wave. So again, we didn't identify any. It was before that first kind of peak. There may have been some, but we didn't identify. In the 21 to 22 cohorts, that was at the end of wave 2 and included waves 3 and wave 4. And again, we didn't have documented COVID positive results in the files to show that these people also had COVID. But what we did see was there was a slightly higher proportion of people that were dying as an outpatient compared to the 2020 cohort. And in that situation, these are the ones we really don't know the cause of death. So sometimes you look at the file and you're kind of seeing like, this, you can suspect what happened because you've seen a trajectory starting in the patient records, but you don't know. So people may have left and died in a car accident, or they may have left and died of COVID, but we weren't able to really access cause of death for those outside of hospital. But for inside the hospitals, we didn't see any COVID deaths recorded.
Okay. I think I'll just remind people whilst I wait for just about 2 more questions, as we have 4 minutes left of the session. Just would like to remind everyone in attendance that if you'd like to see yourself on this platform in the upcoming months, please do email myself at ngosi@tbthinktank.org or anyone else within the Secretariat if you'd like to see yourself on this platform. And we'd like to tell everyone in attendance to please save the date for our special edition webinar on the 4th of March at 12 noon, where we will be going through the key messages from the BRICS Summit that took place late last year. So we have still just under, let's say, about 3 minutes left for just 2 more questions or comments from today's presentation, or if, Louisa, you have any almost final remarks to share with the group.
So Nalvazi, I actually have a question for Louisa.
Okay, go ahead, Priya.
So Louisa, I know you presented, oftentimes we think of mortality and the first thing that comes to our mind is always delayed health-seeking behavior. I know you presented from diagnosis to treatment start that it was about 5.5 days, right? But was there any data around from the first time the individual got ill till they were diagnosed? So I also take cognizance that majority of your patients were inpatients. So I'm not sure if you had access to clinic records or anything like that, but just from the time the patient first started presenting with symptoms till they were diagnosed. Clearly we're doing well, or relatively well from diagnosis to treatment start. But what about prior? Thanks.
Yeah, no, that's interesting. It's a good comment. So we actually started off trying to capture and record that kind of data because we had the same kind of interest. And it's very difficult to capture because unless you've got the clinic card for the local clinic, you don't have that in the DRTB or inpatient files. And it's not, people don't tend to document in terms of, this patient's been to the clinic 4 times before or whatever. So we did try to capture data originally on like how many visits had happened before the diagnosis and how long the symptoms had been present for. But due to sort of documentation, we weren't able to really capture information on that, but we were also very interested too.
Okay, great. And then just 2 more other questions. The first one was any detail around TB preventive therapy that you might have collected on these patients? And then the second question is around what did y'all do with the household contacts? So here you've got a patient who's just passed away from drug-resistant TB. What was the plan in terms of intervening at the household level? Thanks.
Okay. Yeah, so in terms of the TPT, it's not something that we included in the DRTB mortality tool, mainly because you're not in the facility that would have given the TPT and usually has that information. But it is something included in our DSTB mortality tool, because when you're doing DS mortality, you're more likely to be in the facility that kind of has that information available to you. So we would hope to have that information related to DSTB. But not for the DR. And then, the contacts. Yeah, so we were looking back at people who had died sort of 12 or more months ago. So as a program, we were working during the same period. We were working on supporting sites. We were working on contact management for all patients, though. So for anybody diagnosed with DRTB, we were working on contact management, but not specifically on people who had died. We were doing for all.
Okay, great. I mean, I can definitely see the value of supplementing something like this mortality audit with a verbal autopsy, and maybe engaging the family a little bit more and, you know, trying to understand, but also reaching the family and ensuring that we adequately screen test. But thank you so much. That's it from me, Nawazi. Thanks, Louisa.
Thanks, Priya. Thanks, everyone.
Thanks, Louisa. Thanks, Priya. It's 1 p.m. So I think just to ask for 2 minutes, we have a question and then a comment. What was the admission duration prior to death? Any suggestion that patients were admitted too late?
So again, I do have that for the second cohort, but we're in the middle of analysing our timelines for that, so I don't have it to hand. But we did look at that admission duration. Sorry, what was the second part?
Any suggestion that patients were admitted too late?
So sort of presenting with very advanced disease, or admitted too late during treatments.
I think perhaps the second one.
Yeah. So I mean, we are seeing people presenting late. So we've seen that a lot of people are, not, functioning fully, not able to walk on without assistance, and take care of self-care. So we know that people are presenting late. A lot of these facilities did have inpatient facilities, so were able to admit appropriately at the start of treatment. I think one of the gaps that we did note with sort of the recognition and management of SAEs was that things were sometimes a little bit too slow, and there were delays in sort of picking things up and acting in some cases. And in some cases that did include admissions that potentially should have taken place a little bit sooner.
Thank you, Louisa. I'd like to just say again, thank you to our speaker for today. Thank you for your time, and thanks to everyone in attendance. I'd just like to say enjoy the rest of your Monday afternoon and have a productive week ahead. Thank you.
Thank you very much, Nawazi, and thank you for everyone who has attended to listen.
Thank you again. Bye.
Bye.